Hello, it's Mark Chris, Memorial Sloan Kettering, speaking today about a topic that's become quite controversial, and that is the use of postoperative radiotherapy in patients that have complete resections of lung cancers. And in those resection specimens, there's evidence found for spread to mediastinal lymph nodes, so-called N2 disease. There was data from clinical trials and data from a SEER study showing approximately 7% improvement in overall survival in patients with N2 disease that receive postoperative radiotherapy. There has been a very clear demonstration of an improved local control rate in every trial that's ever looked at postoperative radiotherapy. However, there was a randomized trial, the so-called Lung Art trial, where patients were randomized to get port or not. Port was delivered in a way that is not routinely used now. And in that trial, the benefit of port was found in terms of local control, almost a doubling of control within the mediastinum. However, the difference in overall survival was less than 12%. Again, I'm not surprised to see that because the improvement of overall survival is probably somewhere between 5 and 10%. They also found an excess of deaths, likely due to cardiac causes, likely due to the radiation in the radiation arm. The trial used a type of radiation not used at this point. It used conformal. Now we would use 3D. Its ability at the time of the trial to estimate and lower cardiac risk was not what it is today. And what's happened after this trial, the hazard ratio, very interestingly, was 0.86, which is the same as the hazard ratio in that large database study. But the way the design of the trial was, it was not a significant difference. And it's largely been interpreted as saying that port doesn't work. Well, first thing, let's please go to the guidelines. I'm going to go to the ASCO guidelines. It says that patients with mediastinal disease should not routinely get postoperative radiotherapy, but they should be routinely referred to a radiation oncologist for consideration of port. And I don't think anything that's been published so far changes that. I think each case needs to be individualized and requires the special and specialty care of a radiation oncologist to weigh the pros and cons of port. It also depends upon the treatment plan as well. Can the heart be spared? Are there radiation techniques available that would eliminate or lessen heart exposure, such as using protons? But the point is that port is still needed. When we look at the trials of patients receiving adjuvant therapy, what we see is, and I'm looking particularly at the ADAURA trial, where patients received adjuvant osimertinib, the greatest number of failures now are in the chest. And we have to look for good ways to cut down on failure in the chest. Unfortunately, failure in the chest means ultimately failure and lack of cure, and we have to do a better job at that. And I think postoperative radiotherapy can play a role there. So I ask you to please, when you have patients with N2 disease, after the completion of systemic therapies, think about the use of port and get the advice of a radiation oncologist to meet with the patient, review their clinical situation, and assess whether or not port could be useful for that patient. That is following the NCCN guidelines. They were not changed based on this Lung Art paper. And I think we owe it to our patients to make sure that those could benefit from this additional therapy should receive it. I'll put it to you that a radiation delivered in the most innovative way taking very careful account into the effects on the heart can improve local control. There's no question about that. And I think has the ability to improve survival by a small amount, probably less than 12%, which I will agree the LungArt trial showed, but yet an important amount for patients with this condition.